Hello, everyone. It is my utmost pleasure to welcome you to our session on HIV, climate change, and community resilience. This is a session jointly organized by Frontline AIDS, WFP Southern Africa, UNHCR Southern Africa, UNAIDS Eastern Southern Africa, as well as three youth organizations, REPSI Mozambique, Swandiri Zimbabwe, and Y+ Malawi. So it's my pleasure to warmly welcome you today. I am one of the co-moderators for the session. My name is Marietta Wildt. I'm a gender and humanitarian officer at UNAIDS Regional Office for Eastern Southern Africa. As many of you might or might not know, UNAIDS is not a UN agency, but a joint program consisting of 11 agencies working on HIV and AIDS since 20 years. My co-moderator for the session today is Marina Scott, the knowledge exchange advisor at Frontline AIDS, the biggest network of civil society organizations working to end HIV and AIDS. So I have the pleasure to give you a little bit of context to our session today and introduce you to the overall topic before we dive right into a couple of presentations, as well as on an exciting panel discussion between our three youth organizations. So I want to start off and say HIV and emergencies, as much as you might not have heard much about it, is not a new topic. So, for example, there's our Bible on HIV and emergencies, or HIV-E as we call it, the 2010 guidelines on HIV and emergencies that were developed by the Interagency Task Team, which was actually revived last year by UNAIDS, WFP, and UNHCR Global as its core team, which is now working jointly to revise the HIV and emergencies guidelines. And actually, the planning of the session that we are seeing to come to fruition today goes back to one of the consultations for the HIV-E guidelines, which took place last year in December, and where a couple of us got together and got to the idea of having a session at OCHA's Humanitarian Partners and Networking Week. I do want to say that the push to work more on HIV and emergencies is actually coming from communities. So UNAIDS, being a joint program, has regular program coordination meetings, and our NGO delegation in 2023 demanded to strengthen HIV integration in emergencies. So this is something that has led to the revival of the IAT, the Interagency Task Team that I just mentioned, and to strengthen advocacy on the matter. We all know that emergencies, especially those driven by climate change, are increasing. However, still HIV remains overlooked often in this context. So this is one of the first sessions on HIV and emergencies in this space at the HPNW. And I want to give a shout out to our OCHA colleagues, Nat and Clint, who really helped make this come together and to give us this opportunity. So I want to set the scene a little bit. So when we're talking about humanitarian settings, we are including conflict, disasters, forced displacement, and climate-related crises, all of which, despite their nuances, disrupt essential HIV services. So emergencies and their onset and continuously create unique barriers to HIV prevention, treatment, and care. And this normally hits those most marginalized hardest. Especially also displacements due to crises, let it be climate change, conflict, or economic instability, affects millions and exacerbates HIV vulnerability. You will see that this session has quite a strong focus on Southern Africa, which is particularly vulnerable due to its high HIV prevalence, its fragile health infrastructure, and of course, increasing climate shocks. So why are we speaking about HIV and emergencies? So first of all, we need to understand that the risk is elevated in this setting because people living with HIV face compounded vulnerabilities. So that is stigma and discrimination, that is limited access to HIV treatment and care, for example, because of disruptions in stock out of medication and prevention commodities like PrEP or condoms. But of course, the nutritional challenges in crisis impact the level of treatment adherence of people living with HIV, as it is harder to take the drugs on an empty stomach. In addition, people living with HIV often face barriers to accessing protection services. So, for example, due to stigma and discrimination, specifically of the most vulnerable, the key populations. This means there's a heavily increased risk of HIV transmissions in conflict due to sexual violence and exploitation, due to disrupted prevention services, and of course, due to displacement and loss of social support networks. So all of this increases the chance that HIV gets transmitted. You'll see from our panel discussion that we are looking heavily into the role of youth in the response to HIV and emergencies. So you might ask yourself, like, why this focus? So I want to emphasize that youth bear the highest burden of new HIV infections in sub-Saharan Africa. So, for example, in East and Southern Africa, specifically in 2023, 2 in 5 new infections were among young people between 15 and 24 years. And again, out of those, 3 in 4 were among adolescent girls and young women. It's important that we look at HIV as a multi-sectoral issue. HIV and emergencies is not just a health issue. It intersects with many others, as you have seen from what I said before. So this could be protection, nutrition and food security, livelihood and economic stability, and education. Our colleagues from Frontline AIDS will give a presentation on their HIV and climate change framework after this, and we'll delve deeper into what this means and how this informs our response strategies. So, while this session is certainly not focused on the current funding crisis and USAID withdrawal, I do want to acknowledge the context that we are in, because, the USAID withdrawal has heavy impact on our region geographically and on the themes of both humanitarian work and HIV. So a little bit of data on this. So, for example, we are seeing that access to treatment and prevention services have been disturbed across the board in our region. So, for example, there's a survey done by our partner, ICWEA, that says that over 20% of the respondents indicated experiencing challenges to accessing treatment and other health services because of service reductions, clinic closures, and medication shortages. Stigma and discrimination are at an all-time high, and there's a high risk of gender-based violence, which means, as I outlined, increased risk of HIV infection and vulnerability. This is especially hard on women living with HIV who face increased stigma, and on young women who have reported in different surveys, reported a heightened fear of violence and specifically of gender-based violence because of cessation of gender-based violence prevention programs. We see across the board that organizations, especially community organizations, are defunded and disrupted. We had humanitarian waivers at the beginning of the stop work order, which were not implemented in most countries. And as a result, we are seeing increased risk of HIV transmission, worsened health outcomes, including on mental health, and generally a setback on community-led responses. If you would like to hear more and updated data, please take a look at the UNAIDS website. So, of course, we need to ask us, what does this mean for us jointly? I think it's a massive call to action for resource efficiency, for collaboration, and of course, advocacy, as we are doing today. So we see a need to leverage the existing resources we still have, to leverage community leadership and innovative approaches to sustain HIV services in humanitarian contexts. So, thank you for listening to me until now. Let's get right into the session. So we will start off with a presentation by my colleague, Alison Wilson, about Frontline's Climate and HIV framework, which was finalized last year. Afterwards, we will have a presentation by Anjali Rabat, who's a consultant commissioned by UNHCR, WFP and UNAIDS, my apologies, on El Nino and the levels of HIV integration in the responses to the last El Ninos, 2015 and 16, and 2023-2024. And after that, As I mentioned before, we'll have a panel discussion by 3 youth organizations, which are REPSI from Mozambique, Swandiri from Zimbabwe, and Y Plus from Malawi, moderated by my co-moderator, Marina. So I'm excited for Alison to start her presentation. Alison is a senior advisor at Frontline AIDS and works in funding and partnerships and coordinating Frontline AIDS' response and work at the intersection of HIV and climate change. Alison, please get us started. Thank you.
Frontline AIDS began looking at HIV and climate change around 3 years ago. We have a small internal working group made up of colleagues from across the organisation who have been focused mainly on understanding the evidence around the effects of climate change on HIV and how our partners and the communities we work with are being impacted. What we found is the links between climate and HIV are often under-recognised in research and practice. But climate change could be devastating for the HIV epidemic globally. This led us to publish our evidence brief in December 2023, which I'll present to you today. Within the brief, we have our framework, which demonstrates the effects of the climate crisis on HIV and some case studies from community-based partners. The brief and framework were informed by conversations with Frontline AIDS partners, funders, and many other individuals interested in the health-climate intersection. We conducted an extensive literature review, and the framework paints a holistic view based on the evidence of the many ways climate change affects the communities most impacted by and people living with HIV. The details of the papers, articles, and sources are in the brief if anybody wants to take a closer look at the evidence. Before we look at the framework, I wanted to start with some of the evidence, and on the slides we have 2 statistics that came out of the literature review. In the first, we see if current trends continue, we could be looking at between 11.6 and 16 million additional cases of HIV in sub-Saharan Africa by 2050, which would be an increase in HIV prevalence of 1.4 to 2.1%. That's from a paper published in 2020. The second study demonstrates increased HIV prevalence rates linked to drought. That's from a paper published in 2022. So what the evidence shows is that while climate change doesn't directly influence the HIV virus itself, climate change can and does increase rates of HIV and negatively affects the health and well-being of people living with or affected by HIV. This is Frontline AIDS Climate HIV Framework, which we'll take a closer look at now, layer by layer. At the top, we have the consequences of climate change most relevant to HIV. As identified in the literature, these are weather-related disasters, sea level rise, changes in precipitation and temperature, and air pollution. It's important to note that these are highly location-specific and could look quite different in different geographies. Next, the evidence shows there are a range of interconnected pathways that lead from the consequences of climate change at the top to the HIV-related health outcomes at the bottom. The pathways are all interconnected and are very difficult to separate out, but taken together, they lead to reduced health and rights related to HIV. Firstly, we have increased human migration. This is both the displacement of large numbers of people all at once in the face of a major environmental event or disaster, and also the slow, steady movement of people as temperatures increase, rainfall decreases, and crops fail. Migration can be significant and devastating, affecting livelihood support systems and communities. In sub-Saharan Africa, it's estimated there will be 86 million climate migrants by 2050. A study in Lesotho found climate migration doubled a young person's odds of acquiring HIV. Next, we have increased prevalence of other diseases, which includes waterborne diseases in the case of flooding. Vector-borne diseases where temperature increase due to climate change means the mosquito that carries malaria is able to survive in new locations, which is projected to include the highlands of Ethiopia, Kenya, Zimbabwe, and South Africa, and also increased zoonotic diseases. Studies in Malawi and Uganda have shown increased HIV viral load in patients at the time of malarial infection. Increased food insecurity, both for subsistence farmers and people purchasing food. As crops fail, food gets more expensive and harder to access. This applies to plant and animal crops and also fish, as increased water temperature has a negative effect on fish stocks. Food insecurity has been linked to increased transactional sex, heightened risk of condomless sex, women's disbarment, poor ART uptake, adherence and efficacy, poor immunological and virological responses, higher mortality, and earlier sexual debut. Next, increased economic stress. This applies to agriculture, but also has a knock-on impact across all other sectors. The majority of people living in poverty depend on agriculture and natural resources for survival. A systematic review looking at the impact of drought on ART adherence found economic and livelihood-related challenges had the strongest impact on non-adherence. Increased conflict, terrorism, and ecofascism. What we're referring to there is a rise in nationalistic and white supremacist sentiment in response to climate change, which in turn causes people to close borders and not share resources. Very often, marginalised communities, including LGBTQI+, and people living with HIV are blamed and targeted for harassment or violence. And finally, an erosion of the health infrastructure, which includes weather-related disasters affecting the physical infrastructure, destroying medical records and disrupting medicines and supply chains, and health systems being stretched by the increased burden of disease. These pathways lead to reduced health and rights related to HIV. Climate change doesn't directly influence the HIV virus itself, but it results in changes in environmental and social systems that impact everything from how HIV infections are transmitted and contracted to how likely or unlikely people are to live well with HIV and the level of AIDS-related deaths. On the left, we have increased rates of HIV. On the first slide, we saw the modelling from 2020 that indicated a potential additional 11.6 to 16 million cases of HIV by 2050 as a result of climate change. This is in part due to reduced access to prevention services, which could be due to the erosion of health infrastructure or the displacement of large numbers of people in face of a humanitarian crisis who don't have access to services at all. It can also be because individuals with increased economic instability don't have the means to access the services. This includes PrEP, HIV testing, HPV vaccines, etc. In 2009, after flooding in Namibia, 87% of people living with HIV reported disruption to services, and 23% reported missing their medication. The evidence shows increased risk situations as a result of these climate-related pathways, including GBV, child marriage, and sex work, all of which are linked to increased rates of HIV. In Malawi, it's estimated extreme weather has placed 1.6 million girls at risk of becoming a commodity as brides, as their families are unable to feed them due to climate change. We also see reduced health and well-being for people living with HIV. This includes reduced access to ART and mental health services. The effects of climate change and the pathways are drivers of stress, which increases the need for mental health services. In environments with increased food insecurity and economic stress, we see reduced nutritional quality, which is important as this has an impact on the effectiveness and adherence to ARVs. Finally, we also see increased morbidity and mortality from other diseases, and increased discrimination and abuse due to HIV status, gender identity and expression, and sexual orientation. Alongside this, the evidence shows there are a couple of amplifiers which exacerbate this cause and effect relationship. The first is the social determinants of health, which are the individual characteristics like sex, level of education, income, etc. There is significant overlap between communities that have increased vulnerability to the climate crisis and those who face barriers to SRHR and are at increased risk of HIV. The social determinants of health compound and magnify outcomes relating to both HIV and the climate crisis, so the populations who are most marginalised are also most disproportionately affected. The capacity and resilience of the health system and government response is also important when it comes to climate consequences. For example, if health systems have put in place adaptation measures to counter weather disruption, such as ways to transfer medical records and treatment regimens, or backup power, water, and staffing plans, the same climate consequences can have vastly different outcomes. The resilience of the health system supply chain is also critical, as well as the government's ability to provide education, temporary housing, and other support. You may notice our framework demonstrates only the impact of climate change on HIV and not the reverse. This was a deliberate decision for a couple of reasons. Firstly, we didn't find any specific evidence quantifying the extent to which HIV could fuel further climate change. We know, broadly speaking, the health sector contributes around 5% of greenhouse gas emissions globally, but 65% of that comes from just a few countries. We also know that people who are most vulnerable to HIV and people living with HIV are not significant contributors to climate change, so we focused the framework accordingly.
So I'll start with a little bit of the scope and objectives of our project. We wanted to really focus on the impact and responses that the El Nino drought events had on HIV in Southern Africa, really considering SRHR, gender-based violence, food insecurity, vulnerability, and displacement. So our objectives were fourfold, really to do a comparative analysis, looking at 2015 and 2016 and 2023 and 2024, and to really improve what are the future lessons here for emergency responses, and what were those lessons learned from the first drought response we looked at actually implemented in future drought response. We really wanted to focus on addressing some of the critical gaps, so identifying the overlooked links that are between HIV, food security, displacement, and in humanitarian efforts, and really look at what are the actionable insights and lessons. What can we do using the evidence and lessons learned, and what recommendations can we make for a holistic response that really promotes an integrated approach to HIV and considers climate emergency preparedness and responses. And lastly, to have an advocacy tool. So we're hoping this research will be able to support efforts to with governments, development partners, donors, to really have HIV integrated into the emergency response. So the countries that we focused on were these 6 countries who did declare, can you click please, who did declare a drought emergency. And next slide, please. And the methodology that we used was we had a desk review of reports, literature, paper, any documents we could find. And then we had key informant interviews. We did 27 key informant interviews, technical consultations that were held with everyone from regional level, country level, and community level. So this included partners from OCHA, from UNFPA, UNAIDS, the larger multilateral organizations, country level people working for these organizations, community level organizations, as well as even some healthcare workers and people working in communities. And we took those 2 things and synthesized those to receive our findings. Next slide, please. So let's start by comparing the drought response from 2015 and 16 and 2023 and 2024. So in the first response, there was about 32 million people affected, and some of these numbers vary. So these are the numbers that I've found mostly reported. So 32 million people affected versus 36 million in need of assistance in the next in the other response that we're looking at. The El Nino in 2015 and 16 was classified as very strong, but the 2023 and 2024 El Nino was climatically weaker, but it really impacted many more countries and with a greater intensity. And a lot of the countries were already going through compounding crises at the same time, things like mpox, cholera outbreaks, conflicts, floods. And so you can also imagine that as you move forward and you've kind of gotten rid of your reserves, it gets more difficult to respond. So that the amount in humanitarian appeals that was requested was different, with about 2 to 3 million, 2.5 to 3 million, it's been 5.5 million. So more financing was needed. And we had about 29 million people facing food security, about 27, so almost the same. Click, please. And the HIV specific impacts, there was a study done over multiple countries from 2003 to 2009 data, and it looked at every exposure to a drought increased HIV infection rates by 11% in HIV endemic or high prevalence rural settings. So you could imagine, as this is a thing constantly happening, we could have increased rates. But in both scenarios, there were reports of decreased HIV testing in increased high-risk sexual behavior and disruptions in access to HIV prevention and treatment services. Next slide. So I'm going to move into the lessons learned and recommendations. So one of the things we found is that preparedness improved between the two time points, but gaps still remain. So what really worked well was SADC's phased plan for the El Nino preparedness and response. It looked like that was a great opportunity to bring people together, to define people's roles. The partnership with the Famine Early Warning System Network was described as really providing accurate information where people could pre-position supplies and really understand where the impacts were going to be and improved risk communication. But with that, the response capacity was still insufficient for the crisis scale. And there was a lot of discussion around the early warning systems not being sufficient to reach those who most need to hear it. Some farmers in rural areas, the languages not being appropriate for those farmers and rural affected communities. So in the future, we really need to focus on strengthening and funding regional early warning systems and developing some kind of standardized checklist or cross-sector preparedness tools and checklists. So the lesson here was really to invest in preparedness and anticipatory action. We also found that coordination had improved regionally across partners and locally. So what really worked well was RIASCO, which is the regional OCHA-led forum of humanitarian partners, really helped strengthen the coordination mechanisms through this phased response plan. So I think from what we saw, a lot of people were saying that having this kind of standalone committee for this really brought people together, helped people identify their needs, helped avoid duplication of resources, and these partnerships with countries facilitated the response gaps and escalation efforts that needed to be there. However, there were administrative processes that sometimes hindered the cross-sectoral action, and I think we see this a lot, especially in this study, the multi-sectoral and cross-sectoral, everyone's still working in their silos. That's something we need to really keep in mind moving forward. So we need to facilitate regular cross-cultural coordination meetings, information sharing, more collaboration, more communication across different sectors, and by establishing sector-specific working groups for technical staff, that is one way that could help. And really establishing clear roles and communication channels among stakeholders. So the lesson here is really that we need to continue to support and strengthen coordination. We did see some innovative HIV care models. So some things that worked well was providing 6 months of ART supplies to improve retention and care so that when there was any kind of emergency and if people were displaced or migrating, they were able to have supply with them until they could connect with the health system again. Mobile clinics also enhanced access to HIV treatment and care in remote areas. In Zimbabwe, they had HIV outreaches with viral load testing, which really helped with staging and testing and making sure that everybody was getting the care they needed. However, there were still stockouts of ART and family planning commodities that were identified, so that's something that needs to be addressed. So in the future, we really need to focus on scaling up decentralized and community-based HIV service models and investing in climate resilient storage facilities for HIV commodities so that they are not destroyed when climate emergencies come. So the lesson here is to work with communities to strengthen community-based HIV care models with considerations for climate change, and especially those that are context specific and work in the communities. Next slide, please. Some challenges to HIV integration that we found was what worked really well. There was an example coming out of Mozambique where they had an HIV focal point in their national government level for emergencies. So when emergencies came up, HIV was considered because there was somebody's job to consider HIV. So that was a good system that seemed to work well. However, there was lack of guidance and prioritization of HIV integration across humanitarian clusters. And there was definitely a need for more clear guidelines for HIV in all aspects of the humanitarian response. So, an example would be the IASC guidelines and having them more integration focused. So, mainstreaming HIV into climate preparedness and emergency response plans needs to be emphasized more in the future. And the lesson is to continue to advocate for the integration of HIV, SRHR in emergency responses. A great example of an HIV and nutrition integration model, and I'm happy to provide more information on this as well. It was the PEPFAR World Food Program collaboration, and this was a one-off collaboration in 2015 and 2016, which really improved HIV prioritization and access to support. So they had the integration of HIV screening in nutritional rehabilitation programs, and it really solidified that link between HIV and nutrition. However, in some cases, there are reports of increased workload if people were being seen for HIV. Now, healthcare workers who weren't as familiar with some of the nutritional supplementation and commodities had to figure that out. And there was a lot of discussion around challenges in distribution schedules, so between the ART and the food commodities, and things like where do you store in a clinic these sorts of commodities when you're a health-focused clinic. So yeah, I think we really need to invest in integrated HIV nutrition and livelihood support programs. And if we have digital supply chain management systems that could address the distribution schedules, and looking at integrating HIV nutrition and the drought response together. So we really need to learn from models like this one and replicate the successful integrated models for HIV and nutrition. We also found a need for greater community engagement, and this was a very overwhelming need because there was very few and sparse real examples that we could learn from. And I know there's a lot of really great things happening. I'm not sure it's getting documented. So what really worked well was a lot of community-led initiatives using social media for fundraising and distribution of supplies in Malawi. So for example, communities would come together, they would figure out another community that maybe was in need, use WhatsApp to organize the items that might be needed, pool the funds, purchase the things, post the receipts, high level of accountability, and really an immediate response. However, youth were often not incorporated into the long-term planning, and this is something that came out strongly, where they were often engaged late in program design processes, and also there wasn't a lot of representation I found from key and vulnerable populations, so that's something that definitely needs to be addressed. So in the future, we need to look at mandating meaningful community participation in all stages of the emergency response and establish regional community engagement frameworks and platforms. So the lesson here is to really improve community engagement on HIV and SRHR in emergency preparedness, response, and recovery, especially of key and vulnerable populations. There was also a lot of challenges I saw with data management. One thing that worked was having electronic facility data versus paper copies. So there were some reports of people being able to, even if they had lost their health cards or health passports, they could show up at a clinic further away and all the information is on file. And that was a great success for tracing people with HIV and connecting them to the appropriate care and knowing their comorbid conditions. However, there was a lot of difficulty in obtaining systematic data on climate impacts of HIV, on the climate emergency impacts of HIV. And the data is not often shareable between agencies and sectors. And so this is something that really needs to be considered. So if we could develop shared data platforms for real-time information sharing, that could inform the real-time response to make sure we're meeting the needs of the population that need it the most. So strengthening data collection systems that capture both HIV and climate-related indicators should be a focus in our future. So the lesson here was integrated real-time shareable data systems are crucial for effective HIV care and climate-related emergencies. Gender-based violence prevention got more focus in the second round and had improved. A lot of examples came forward, like in Zambia, the training of community health workers or volunteers as gender-based violence monitors. So they're people from the community, embedded in the community, linked to local police, the health sector, and the integration of GBV prevention in outreach activities. So prevention, but also response to victims of GBV. So if there's a case of rape, they're directly linked and counseled and tested and potentially offered treatment for HIV. However, there was a lot of examples of weak reporting and referral structures within the communities. And a lot of it is probably determined by insufficient resources for community victim support units and for training on gender-based violence for community organizations. So I think in the future, we really need to focus on strengthening GBV prevention and response across all sectors of the drought response and across all levels as well, and provide dedicated funding for organizations to support vulnerable groups. So the lesson here is integrating the prevention and HIV outreach is crucial, but requires stronger community support systems and cross-sector funding. So in conclusion, we really need a paradigm shift in the way that we think about HIV and emergencies, especially in this climate context. So we really need truly integrated multi-sectoral approaches that safeguard HIV progress and really address this complex interplay that Alison laid out really well of HIV, gender-based violence, SRH, and forced migration. So it's imperative that HIV and SRH considerations are mainstreamed into the climate adaptation strategies and broader response. So the path forward requires sustained political will and commitment to community engagement and preparedness, increased investment in integrated approaches across sectors that includes data, funding, planning, preparedness, community-led programming and governance, and the voices of those who are most vulnerable really need to be prioritized in all stages of the planning and implementation, including community-led work. So as climate change continues to exacerbate existing vulnerabilities and create new challenges, the global community must act with urgency and commitment. So thank you very much. Here's my contact information as well, if you have any questions or would like to chat. Thank you.
Thank you so much, Anjali, for presenting your findings and especially laying out the path forward. I'm happy to say that obviously we're already following some of your recommendations of continued HIV and emergencies advocacy through the session. I want to add that we are currently working on turning these findings into an easy access tool that we are happy to share widely in a couple of weeks. And that we are also working on like a guidance document of easy access models of HIV integration. Yeah, my co-moderator Marina, I hope we can see you. And we are now gonna delve right into the most interesting, I'm sorry, Alison and Anjali, but into the most interactive piece of the session today, a panel discussion with 3 community-led youth organizations. Marina, please take it from here.
Thank you, Marietta, and thank you, Alison and Anjali, for the evidence. Can you hear me well? Yeah. Okay. My name is Marina Scott. I work at Frontline AIDS, and I'll be the moderator for the panel discussion. At Frontline AIDS, our biggest program is called READY, and that stands for Resilient and Empowered Adolescents and Young People, and it's designed to improve access to HIV and sexual and reproductive health services to adolescents and young people. It's a program that exists since 2016, is being implemented in 6 countries across Southern Africa with 9 consortium members who lead different countries and different technical areas. And we have 3 of these organizations with us today, which are Y+ Malawi, Zwandiri, and REPSI. So let me introduce you to your speakers. We have 5 speakers in the panel. We have Maxwell Matiwa, who's the district coordinator for Y+ Malawi. We have Elena Masinga, who is the national coordinator for Y+ Malawi. We have Marta Mawadzeke, who's the head of technical assistance at Zwandiri in Zimbabwe. We have Julia Mutemba, the country director for REPSI Mozambique. And we have Ivan Nazare, who's a community adolescent treatment supporter from Mozambique. I hope you can see their faces. Please go on camera. And I will, I'll give the floor to the speakers now and ask them to briefly introduce their organizations, the communities that they serve, and the climate events that they have responded to. So we'll start with Max from Y+. And Alison, are you able to share the slides? And Max, please go ahead.
Thank you so much, Marina, for giving us the platform that we can share what this organization is all about. So as Marina has already introduced, this is Max Ntiva. I'm working with Y+ Malawi. So somebody might ask, what is Y+? So this is a National Association for Young People Living with HIV, and it was established in 2014. Our main focus, we are focusing on young people living with HIV, especially from the age of 10 to 35 years. So in Malawi, we are having 28 districts as a country. So we are in all those 28 districts working with people, young people living with HIV. So our special area of specialization is to empower and demand provision of quality HIV and treatment, care and support to young people living with HIV across the country. So the approaches that we use, we always have the advocacy, we always do capacity building trainings, peer-to-peer learning, skill development, and media communication, and partnership collaboration, and the networking. So currently, we have more than 5,000 members across the country. So whenever we're talking about these 5,000 members, we're talking about young people that are HIV positive. Somebody might ask, why are we in a humanitarian setting? In Malawi, past 2 years, especially in 2022, we were hit hard with a cyclone Fred, and we've been affected greatly as the country. Not only that, we have been having different kind of disasters, but most importantly, I should mention cyclone Fred and cholera, the main disaster that made us to be in the humanitarian setting. So thank you so much. I think I'm with Irina. Can speak something on that. Thank you.
Thanks, Max. I'll give the floor to Mater now from Zwandiri.
Good afternoon, good morning to you all. It's my pleasure to be here. My name is Martha from Zwandiri. Zwandiri is a Shona word from Zimbabwe, which means accept me as I am. And we are located in Harare. And the Zwandiri model is being implemented here in Harare. And also it has been adopted across the region in 15 countries, including Zimbabwe. And our focus group that we work with are children, adolescents, and young adults who are living with HIV, 0 to 24 years. We specialize in peer-led counseling and support for children, adolescents, and young people to improve their health and well-being, which means at the forefront of our implementation are young people who provide these services, which include counseling and other services. And currently, we are supporting around 190,000 children, adolescents, and young people living with HIV. And these are supported by 5,500 peer supporters, whom we call kids or young mentor mothers. And the evidence that we have to date shows that with this intervention, we are seeing more than 95% viral suppression amongst the cohort that we are supporting, and also 42% reduction in virological failure and death amongst this cohort, and also 60% reduction in symptoms of common mental health disorders. And we have also been involved in responding to crisis in Zimbabwe, where we have responded to cyclone Idai, floods, and some droughts, which we normally experience here in Zimbabwe. So you see in that diagram, which is to my left, it shows that we've got ART and the young people who are supporting their peers in terms of staying and retaining on treatment. So if we combine those two, we've got ART and the young peer providers who realize these social constructs amongst the cohort that we are supporting, which includes hope, self-acceptance, self-efficacy, purpose, connectedness, and flourishing. And what does this lead to? It leads to good adherence amongst the cohort that we are supporting. It also leads to good mental health and well-being. And ultimately, we have children, adolescents, and young adults who are able to survive and thrive despite the fact that they are living with HIV. And the cross-cutting theme that we work with is ensuring that we are building the system so that at least it is able to support children, adolescents, and young people who are living with HIV. And we do this through working with governments and implementing partners in the different countries that we are working with. Thank you.
Thank you, Mater. And the next person is Julio from Mozambique.
Thank you. Good afternoon. My name is Julio Mudemba, Country Director for REPS in Mozambique. I'm working for REPS, which is a regional psychosocial support initiative. REPS was born in Zimbabwe around 2002 to respond to the crisis of HIV, AIDS, poverty, and the conflicts, which we called the triple crisis those time. And in 2005, it was registered in South Africa as an NPO, and it grew to cover around 13 countries in East and Southern Africa. Our focus group are children, youth, boys and girls. We are quite specialized on mental health and psychosocial support. So we use mental health and psychosocial support to improve HIV outcomes, SRHR outcomes, education, livelihoods, and even emergency outcomes. Currently, we are working, our work is benefiting around 20,000 and for males, that includes adolescent and young people, and the 29 and the 465 female. The climate events that we have been responding recently included the cyclone Idai and the Freddy, and we had massive floods last year in Maputo, but we also have a many
Thank
sorry.
you, Jim. Oh.
Sorry, don't tell me I was talking alone. Okay, sorry, I will try to be quicker. So my name is Julie Mutemba. I'm working for REPS. REPS is the Regional Psychosocial Support Initiative. Was born 2002 in Zimbabwe, and it currently covers 13 countries. We are working with the children, youth, and boys and girls, and we are specialized in mental health and psychosocial support. We use mental health and psychosocial support to improve HIV outcomes, early child development outcome, HR outcomes, protection, sustainable livelihood, and the disaster risk reduction and humanitarian response. In the recent years, we've been responding to crises like the cyclone Idai and the Freddy, and the floods in Maputo, and the armed conflict in Cabo Delgado province. Thank you.
Thank you, Julio. And I could hear you very well, like the 2 times. So no worries,
Okay.
we heard you. Okay, thank you so much for the introduction. So as you can see, these are HIV organizations, but suddenly, you know, we found ourselves working in humanitarian settings, and that's not only in Africa, like all over the world. All of our partners are having to operate in crisis, like conflict in Ukraine, like in the context of mass migration in Latin America, climate change events, etc. So we're going to talk now about coordination between humanitarian actors and HIV organizations. And my first question is for White Plus. So for Maxwell, so when a climate emergency comes, what gaps do you see in terms of HIV service continuation during the crisis? And the people that you work with, are their needs being covered? And if not, why not? So that's a question for Max.
Thank you so much, Marina, and thank you so much for the platform, for recognizing my part to have to be on this panel, especially to share experience we have in humanitarian setting in HIV response. So as I earlier communicated, Malawi has been facing a lot of natural disasters, being it cyclones, flash floods, and prolonged dry spell. In these natural calamities, young people living with HIV faces a lot of challenges, and there are a lot of gaps that we experience. So we can run out from treatment interruption during these emergencies. As we are aware that during natural disasters, there's the relocation of people and migration of people from one place to the other. So most of the times during the crisis, you understand that people migrate at least to find a place where they will be free and they will be accessing their basic needs. So you understand that even if they can be at that place, it might be at a rehabilitation center or even anywhere, even at the school. In those places, you understand that there's no access to HIV treatment, no ARVs there, no viral testing there, no CD4 count there, no refilling of ARVs there, including even the important services like PrEP, even the condom. So what they are there for, they're just there to find their basic needs, food and shelter. So you can see that there's a big gap, especially in terms of HIV programming. But not only that, during the crisis, a lot of HIV funding are diverted from HIV to natural disaster management. So you can see that a lot of funding that was helping people living with HIV, at least to make sure that their lives are being promoted. All those resources are diverted. At least they should, at least once they are diverted, they're going to a humanitarian need, forgetting the welfare of people living with HIV. And we might as well agree here that effective HIV response relies much in a community involvement. But during crisis, community structures get weakened, leading to disconnection between the service providers and the clients. And you have asked me another question, that our people that we are taking care of, their needs being addressed. The answer is no. And you might ask, why not? You can see that there's overlooking the needs of young people living with HIV are overlooked during planning, even during the response. And they focus much during the disaster. They always focus to children and others, forgetting the vulnerability of adolescents living with HIV. And I'm here at least to appreciate and recognize YPLUS Global and the AIDS Force from at least the partial support that they always give us in time of need, in time of crisis. And there's no unique program that support and target specific needs of young people during disaster, like psychosocial support, education, even access to ART. So you see, the government, even the organization, are just there to provide the basic needs, forgetting the special needs of young people living with HIV. And on the same, there's a communication barrier. The vital information regarding to HIV services are not effectively communicated to people living with HIV, leaving them with a knowledge gap during the disaster. They don't even know where they can even have emergency ARVs. They don't even know where they can have condoms. They don't even know where they can have whatever need. If there are some things that are being targeted, they're just targeting children and maybe others. But the people that we are taking care of, their needs are not being taken care of. Thank you so much.
Thank you, Max. And you raised a lot of important points there. I will pass now to Julio to talk about Mozambique. And in Mozambique, in 2019, in March 2019, the humanitarian cluster system was activated to respond to cyclone Idai. So I want to hear from Julio, like in your context, how well do you think HIV is integrated into humanitarian responses? And noting that the humanitarian cluster system was activated, how was your collaboration with the clusters? Can you tell us some successes and challenges? And yeah, the floor is yours, Julio. Julio.
So I was saying that within the humanitarian context, a cluster was formed, as you said, and within the were cluster that dealt with different aspects of the needs of the affected people, like protection, food, MHPSS, health. And what we have observed was that and experienced that the HIV responses was not given prominence, immediate prominence in the response. The issues of HIV the response in regard to HIV came a little bit much later and was quite slow, especially among displaced people in the settlements. But despite of that, there were some success because there were efforts that were made. Although even if the process was slow, there were efforts that were made to ensure that the people living with HIV continued their treatment through the centralized distribution of the antiretroviral medication in mobile units and the temporary accommodation centers. There was the creation of a safe space where beneficiaries could receive HIV-related service, including mental health and psychosocial support. Some of the challenges that they were experienced in terms of integration to humanitarian response of HIV was non-prioritization of HIV services. We say the main focus initially was given to food, shelter, sanitation, and the other needs, while HIV was often treated as a secondary aspect. There was also disruption of the drugs stocks or lack of a prioritization or distribution of drug supplies, leading to some beneficiaries and leading to non-adherence and increase the risk of HIV resistance. There was also non-creation of adequate conditions, space where people can access medication without facing stigma and also without the fear of exposure. In regard to the coordination within the cluster, there was a relatively good coordination because there were subgroups or subcluster. So there was a good coordination within the subgroups, like the protection group, the health group, and the nutrition groups. But there was a challenge in terms of the intersectoral coordination, like the different subgroups within the humanitarian class to communicate among themselves. We also observed that there was no actually knowledge or even practice of the HIV EIC guidelines among the stakeholders. Thank you.
Thank you, Julio. Thank you very much. And yeah, and it's also good to know whether the guidelines, whether people are aware that the guidelines exist or not, because that's also part of what we want to do here, is bring awareness that actually there is guidelines on this, so we should all be aware and push for those to be implemented. And they are being reviewed, and they're being strengthened, but they already exist. Thank you so much. So we're going to move to Zimbabwe now. Zimbabwe was also affected by Cyclone Idai in 2019. It has also been affected by floods and drought more recently. But in the context of Zimbabwe, the Zimbabwe government has coordinated the relief efforts. So we want to hear from Zwandiri, how did the coordination between HIV and humanitarian actors work in Zimbabwe, in your experience? What went well? What is going well, and maybe what is missing? And that's for Matter.
Thank you so much. I hope you hear me well. We're just experiencing a heavy rain. Yeah, so I do hope you all hear me well, considering all the rains are outside. Yeah, so for Zimbabwe, yes, definitely, we do have a structured coordination mechanism when it comes to responses to crisis. And what has been quite good about Zimbabwe is all our humanitarian responses are led by the Department of Civil Protection and Ministry of Health and Social Services, while our HIV responses are largely coordinated by the Ministry of Health and Child Care and National AIDS Council. So you see that from these structures, it really demonstrates a structured way in which the different players will respond in case of an emergency. And the good thing about it all is the government is taking the coordination role to ensure that all these responses are well structured in case of any crisis. So yeah, what has been going so well in terms of this is in Zimbabwe, we've established a framework which looks at risk management, which we call the disaster risk management policy. And this policy really guides in terms of coordination efforts for all the involved actors. This then helps to ascertain that there are no duplication or overstepping in terms of responding to a crisis. And we also do have an intersectorial collaboration where government ministries, our UN agencies, NGOs, and community-based organizations do collaborate, work hand in hand to respond to HIV and humanitarian crisis. And you see that these structures, they go down to, they start from national level, provincial level, and they also go down at district level, where we also have established structures such as the district AIDS committees and civil protection committees, which facilitates also coordination at that local level, which then allows for local responses in case of an emergency. Of course, with all that is going well, we also do have some issues which could be missing in terms of all this framework and all the structures that we have put in place, which includes, of course, insufficient funding, which at times hinders government's ability to effectively coordinate the responses to HIV and humanitarian crisis. And I also speak to issues of maybe lack of within government institutes, where we may have lack of capacity, which is not limited to human resources, which includes human resources, infrastructures, which are then will require or limit effective coordination responses. And we'll also look at community engagements, which we really need to strengthen to allow communities to be able to respond to the issues that they are facing, while ensuring that all these responses are tailored to local needs. Yeah, I think for now, this is what I can share. Thank you, and over.
Thank you so much, Matter. So we are now going to dive a bit deeper into specific aspects of their HIV response in humanitarian events. And I would like the panelists to focus their answers not only on how we can engage communities in the response, but also how can we support communities so they can lead the response, so they can sit in decision-making spaces and shape interventions, yeah, rather than bring them at the, as you say, after everything has already been designed. So the first question is for Y+, and Y+ is a youth-led organization in Malawi. So my question is, what are the specific challenges you face as a youth-led organization working in HIV in emergencies? But also, what is the role that you think you can play, and what is your advantage compared to other actors? And that is a question for Elena, who is also from Y+ and is replacing Max.
All right. Thank you very much. It's such a great opportunity to be part of this great conversation. I might turn off my my video just in case of network. I hope that's fine. Okay. All right. Yeah. Thank you. So I think just as Marietta mentioned, when you talk about HIV and climate, for a long time we have taken them like they're two separate things. But for young people living with HIV, I think we have lived the experiences to see that the two actually complement each other. And looking at how climate change has impacted us, even Max already mentioned in terms of young people failing to access their treatment during cyclone, it was very devastating. And looking that we're the most vulnerable youth, we're the most vulnerable when we're talking about HIV programming, and organization like mine, young people, we still today fighting to be heard. We're still fighting to be fully funded. We're still fighting to actually be in platforms where we are contributing to solutions, which is not supposed to be the case. We want to lead because we say youth should lead. So if youth are not leading, then who is? We want to be in the front row and given those opportunities. So one of the biggest challenges for youth-led organization is resources. We have the passion, we have the ideas, we have the solutions, and we've got the plans. So Y+ Malawi actually revised our strategic plan last year with support from UNAIDS, and we incorporated climate change. We have climate change even costed, but we don't have the support to actually start implementing the activities in our strategic plan. So, and majority of donors require a lot of things for youth organization to implement, which most of the time is very ambiguous for us to meet. And we are grateful for organizations such as Y+ Global and UNAIDS who make it very friendly for youth organization to implement. Because with resources, it's easier for us to start incorporating climate change into our programming. And already I mentioned about being in platforms. I know for a long time we talk about meaningful youth participation, and a lot of stakeholders right now recognize meaningful youth participation. But by the end of the day, it's not just putting us on the table. We want the power to make key decision-making, to have the key decision-making opportunities to contribute to different policies and programs. For a long time, yes, we have contributed to HIV, to prevention, but now we're talking about climate change. We don't have opportunities in climate change platforms. And at the same time, the different conferences that are happening, for example, COP29 that happened last year, for my country, I don't think I saw any young person living with HIV presented there. So these are the kind of platforms we want to be in. We want to be part of the bigger platforms of making key decisions, and not only conferences, but we're talking about committees, advisory board, to make sure that our voices are incorporated. Because our greatest advantage is we own the story. We young people living with HIV, we have the status that says positive, and we have got that experience firsthand, and nobody can tell our stories better than we can. So along the experiences that we gather from our communities gives us an upper hand, and also looking at how much we've risen above the challenges we faced around cyclone, and the interventions that we were forced to come up with, the interventions at in an emergency state. That was a big deal, and all those experiences actually give us a big advantage to actually start incorporating climate change. Yeah, thank you very much. Over to you, Malina.
Thank you, Elena. And you made very good points. We're going to move to REPSI now. And REPSI's mission is to provide mental health and psychosocial support to children and young people affected by HIV/AIDS. So the question is, how do you integrate mental health and psychosocial support in situations of humanitarian emergencies, and why is that important? This is a question for Ivan, and he will be speaking in Portuguese. So if you want to hear in English, make sure you're in the right interpretation channel. Yeah? Ivan, please take the floor.
Boa tarde. Respondo pelo nome de Ivan Nazaré Álvaro. Sou CAT do projeto Rede Mais, organização Oasis. Tenho trabalhado no país Moçambique, em Sofala. Sim, respondendo à questão, como a REPS integra a saúde mental e apoio psicossocial emergência humanitária, para garantir uma resposta eficaz em tempo de crise. A REPS implementa abordagem que combina apoiar psicossocial de base, comunitário, capacitação de profissionais e intervenção focadas nas necessidades de criança e jovem. As principais estratégias incluem criação de espaço seguro para adolescentes e jovens vivendo com HIV, estabelecimento de espaço seguro nos centros de aconselhamento onde crianças podem se expressar livremente, brincar e receber apoio emocional. Capacitação de profissionais de saúde e agente comunitário. Formações de CAT, nesse caso que somos nós, em provedores de saúde. Identificação de sinais de trauma e suporte psicossocial para criança e jovem vivendo com HIV. Aconselhamento e apoio psicossocial para adolescente e jovem vivendo com HIV. Sessões de aconselhamento individual e em grupo para fortalecer a adesão ao tratamento e combater a ansiedade e depressão. Engajamento da comunidade e rede de apoio. Formação, promoção de circuitos de cuidados para ajudar famílias e lidar com impactos emocionais da emergência. Obrigado.
Thank you, Ivan. Okay, I'll ask Svandiri now, and maybe to keep your answers just a bit short because we're running out of time. But the last question about specific aspects of the response is for Svandiri. So Svandiri's mission is that all young people living with HIV survive and thrive. And for organizations who might not be used to working with young people living with HIV, what are some practical considerations in involving young people as peer workers in HIV emergencies, in emergencies? And Matter, sorry if you can keep it a bit short, because otherwise we won't have time for final reflections.
Yeah, it's all right. Thank you for that, and I'll try to keep it short. Yeah, so for I will just try to share a few examples in terms of some critical considerations that we will likely need to focus on, and these really fall under safeguarding, since we are working with young peer providers, so that we need to ensure that we protect the health and safety of those young people that we are working with. So firstly, I would maybe need to talk about defining, have a clear definition of their roles and responsibilities, because it will not be a matter of just going there and do the work, but we also need to ensure that they know what they're supposed to be doing, they know their limits. We also do not push them to extremes, like in situations where maybe they'll not be able to cope. Then it is also important to ensure that in terms of capacity building, we need to ensure that these young peer providers are trained, are supported and supervised, so that we equip them with the skills to handle the work, which will be at hand with all the efficiency. And we also need to be sure that we are also looking at their own health and well-being to allow them to work productively and efficiently. As an example, we also need to be ensuring that when they're providing their work or when they're doing their work, we are also making sure that we prevent accidental disclosure of their HIV status. We also need to ensure that maybe if they're working in conflict zones, to make sure that they are safe. We have got an example where we had young people who are working in a conflict zone, and we would make sure that they do not conduct home visits, which of course is a critical component of what we are doing, but because we need to ensure that we protect these young people, we would then not give them we will not then allow them to conduct such home visits, to ensure that they are protected. And above all, we also need to be listening to young people at all the times. We need to learn from their needs. We need also to learn from their experiences as they are delivering the work that we asked them to do. So hence it is critical to always involve them at a design stage, implementation stage, and evaluation, to ensure relevance and effectiveness of the intervention that we will be providing. And maybe finally, what I also need to ensure or to remind us all is that there is need for us to commit to demonstrating their work, their impact, because often at times the work for young people is usually missed, and the impact which they cause is usually missed. Hence, the need for us to ensure that we've got M&D indicators and frameworks which speaks and captures the work that the peer providers do provide. Thank you.
Thank you so much, Matter. I'm really sorry we won't have time for Q&A, and we might also not have time for final reflections from the speakers, but we have heard from all of you. It's been great to hear a diversity of voices and scenarios. I don't know, Marietta, if you want to close us up in the next 2 minutes.
Absolutely. Yeah, apologies to everyone, first of all, for not having space for the Q&A. I'm sure there's many questions. let's post a couple of our contacts in the chat so that we can follow up that way afterwards. A huge thank you to all of our speakers. I personally found this incredibly interesting, and I'm very grateful for the very different perspectives on this that we were able to witness. So from Frontline AIDS and looking at the amplifiers between HIV and climate change to really like hands-on doable ways to improve HIV integration in emergency through the El Nino example. Thank you so much to for the panel. I think it was really interesting to see coordination, for example, through the humanitarian system or through the government. And there were so many other spaces. I'm not even going to try to wrap this up right now. We have 1 minute left. I do want to bring up the IAC guidelines again. I can post a link to that in the chat as well. While, as Marina said, they are being revised, they are still a very usable tool. And a lot of the things that we heard today, both from the presentations and the panel, come up in these guidelines. And I'm actually quite glad that the panel and presentations aligned quite well in their findings. Yeah, with this being said, we're excited to continue working with you. Please get in touch if you have questions to some of the people who spoke today, or if you want to share any other of the work. We are quite connected through the interagency task team on HIV and emergencies, so get in touch if you want to join that. It's a global coalition of various agencies and organizations working on this topic. So yeah, apologies again for the lack of Q&A. Thank you to everybody who spoke. Thank you to everybody who gave us their time and listened. And yeah, I'm really excited to see how this work further evolves, because I think one thing that has been very clear is there's lots of work that's going on. There's lots of expertise. Not all of this is documented. And it is up to us to strengthen this work through bringing to the front what's already happening and learning from the good examples out there. So that being said, we are landing at 4:30 or whatever it is in your time zone. And yeah, thank you again.